I thought I'd do a quick run through on some of the other material that we're covering this week. Um, just quickly here. And we're looking first at the health insurance, chapter 4, as to financing medical care. And there are a number of questions at the beginning. Some of these are a little easier to answer than others. Others depend on how you want to look at the answers, such as, do insurance companies take risk or do they just put a price on it? The answer is insurance companies actually don't take risks. Um, if they insure you, they're going to insure you at a price that they feel will make money. And since the government, state and federal government rules are that insurance companies have to have X percentage of their assets as a reserve to pay for claims, they don't ever lose money. Um, and other things are a little bit clearer here. Um, who pays for the losses? Insurance companies or people who buy insurance? Well, again, since the insurance companies are required by law to have sufficient reserves to cover claims, then it's being paid for by the people who buy the insurance. Same with Medicare and Medicaid. We buy that insurance um, by paying taxes. In the case of Medicare, we pay a Medicare tax in our paycheck. In the case of Medicaid, they come out of state funds that are funded by taxes. So the people who buy the insurance are the ones who pay for everything. Okay, and as for who takes care of people when they can't afford medical care, well, sometimes we do as a society, charity cases, and sometimes we have family and friends and savings. Um, so as a favor from a friend, similar to a loan from a bank, I would argue that the answer is no, but but for the most part, even though there are a lot of things will be done for you just to do them for you, the expectation really is that you will pay them back in some way and somehow, maybe not doing the same thing, or you'll pay it forward. So is it a loan from a bank? Well, probably not, in that a loan from a bank carries interest and other things. But you are expected to, at least in some way, repay that. People with insurance more likely to sustain a financial loss? I think the answer to that is not really. Biggest financial losses we have are catastrophic illness, um, disasters, which we cover by insurance, such as fires to our home, automobile accidents, etc. Um, so I think the answer to that is probably not, because financial losses um, um, come from the inability to cover unexpected expenses. Um, I think that the answer to number 9 has to be um, that company health insurance doesn't change the way people work. People are not going to go in when they don't like a job. They're not going to be enthusiastic just because they have health insurance. And they're not going to work less either, because then they get fired. So who knows? Does insurance increase or decrease the demand for medical care? I think overall, probably the answer to that is that it encourages people to make use of the medical system more. So therefore, the answer to that is it increases. Okay, so there's lots of ways of covering risk. You're going to be reading the chapter, so a lot of this we'll just go through. These are varying. This table talks about types of risk protection. Third-party payment. A third party is rather disinterested. Why do we have third-party payments? Um, they're rather disinterested. To some extent, they help keep They help keep people from overcharging because they know that the insurance will only pay X amount. Health insurance is a funny beastie. When you take a look at the book price of medical care, is significantly higher than those of us who have insurance are charged. The insurance companies make deals with health systems and providers in which they agree that they will be paid X amount for visits. And so that's why we see these statements that say reduction, and you see that there's a reduction that sometimes can be very, very large in the charges. And then you have your copays, which are merely another means of keeping people from overusing the system, really, and reduce the risk to the insurance company. So third party takes a somewhat disinterested, I mean, you're interested in getting the best possible medical care. Doctors are interested in not only delivering the best possible medical care, but also in being properly paid for it. There's this intermediary sort of tries to keep everything a little bit down. So what's a third party transaction? That's when two people are involved and then a third party is actually providing the money. Typical third party transactions are house sales. You have a buyer, you have a seller, and then you have somebody in the middle that's providing the capital, because usually most of us don't have the cash to be able to pay outright for a house. Who pays and how much? That depends on the plan. Also, basically, we all pay. For public health services, it comes out of taxes, out of Medicare, Medicaid, et cetera. Those are all paid for by one tax or another. How are they determined? Well, we have the usual and customary charges. So what happens is insurance companies will look at the standard in an area, and that area can be a county. If you look at premiums for insurance, for instance, in this state, different counties will have different plans available. They'll have different premiums for those plans. So it depends on where you live. A person living basically across the street from you in a different county might actually have exactly the same insurance as you do, but pay a different price. Personal health. Okay, so we have some interesting numbers here. We've got, again, we're looking at 2012 probably numbers, 310 million people in the United States. So the top 1% is 3 million. The next 9% is about 28 million. And then we've got the upper middle is 40%. So that's going to be 50 to 89%. And then the bottom 50% is obviously the majority. So we have, again, $2.6 trillion in 2012 or maybe even 2011 at this point. So the top 1% are spending $500,000 or $500 million. And then the next 9% are spending $1 trillion plus. And the remainder of it, which is about 930 billion here, so is applied to the next 90%. So people with the money are paying money for their health care. Distribution of expenditures. So this is another way of looking at the same individual or the same data. And then we're looking here at statistical information like variability as the size of the risk pool is looked at. Third party, we talked about that. Premiums and taxes are paid to the government and to insurance companies, and then they do the reimbursing. Very little actually goes directly from the public to the providers. This is an example of changes in the system. We have the preferred provider organization. Flex is just a term for a specific plan at Harvard, and then a standard health maintenance organization. The premium in a preferred provider organization generally are higher than in an HMO. And so the numbers here can be seen. Enrollment here is a percentage of 100%. So in 94, 16% were in the PPO and 84% in the HMO. So this is just a percentage of the overall population working for Harvard in those 4 years. Obviously, when they went to one plan only, that's what happened. We don't know why this premium is lower. It could be that your copay is higher. There are many plans where your copay is 15, 20%. There are plans where copays are fixed depending on who you are going to. You may have no copay with your primary physician. You may have a $50 or even higher copay with a specialist. Your ER copays are even higher yet. So there are lots of ways that people are sharing the risk. Moral hazard is really something that is related to the tendency of people with insurance to use the system more. So we're looking at moral hazard here. So moral hazard is the increase in consumption. So we're looking at the price paid with insurance. So no insurance, higher, insurance, lower. So there's this much more utilization or use of the medical system, and that difference between this quantity for no insurance and the quantity for insurance, that difference is called moral hazard. Why, I'm not sure. Well, actually, that's a statistical term, which we won't go into. So it also depends on the price elasticity. So the more elastic the demand curve, the greater the moral hazard difference is. So there is also an issue here of when we look at this, there is a certain amount of the care that is worth less to the consumer, delivers less quality, less service to the consumer than would be warranted necessarily by the price paid by the insurance company, and this is called welfare loss. Tax benefits. Okay, so there is tax benefits happen to be what the difference is when the employee pays for their care and the employer pays for it. Now, of course, very few employers will pay 100% for care, so you almost always have a cost sharing situation there. The effect on labor markets is interesting. Means that as the benefits increase and the employer pays a higher price, the employee takes home less. The wages fall, or their copay goes up, but they take home less. Won't go into the history of healthcare at all here. So let's go switch over to something else. Over here, I think. This wrong? Yes, it is wrong. Come on, wake up. Well, let's see. I thought I had something else. Okay. We'll go over here and we'll go to we'll go to this, and then we'll go here. And we'll go to chapter 5. And we'll just go through parts of this. Chapter 5 is about managed care and insurance contracts. So who is the largest health insurer? That would be the government. There are more people on government insurance plans than anyone else. Which is better, insurance for individual insurance or employer-provided insurance or government insurance? That depends. If you have no access to anything but government, which for the most part, for those of us who are at retirement age or on Medicare, then obviously the government insurance plans. If you can't get insurance, then a government plan like Medicare might be it. How is a state mandate to cover alcoholism treatment similar to a tax? Well, let's look at that. Anything that is imposed on you that costs you money is effectively a tax. We give it different rules, different terms. E470 is a toll road. Well, you can't get on it without paying for it. So, is that a tax? It's not a charge you can avoid. So you have a choice. You can avoid it by simply taking other roads. But if you are trying to get someplace in a hurry, sometimes that's the only way to go. So it costs. Why are so many Americans uninsured? Well, a lot fewer of them now than when this book was actually written. It was written in 2013, and the Affordable Health Care Act didn't really come on board until 2014. But we already know that at that time, there were tens of millions of Americans who had no insurance. They couldn't afford it. They couldn't get it for various reasons. It may be those reasons could range from not being able to afford it because they have no income to not being insurable because of pre-existing conditions or a history of cancer or heart disease or because they smoked or 100 other things. Who pays when the cost of Medicare rises? All of them. But, the government does pay. I mean, the government does involve itself in deficit spending. Insurance companies, not really. As we talked about that before, insurance companies have a mandated requirement to have sufficient reserves. So insurance companies don't lose money either. So how much profit can it make? As much as they can take away. There are very few controls. Most of these HMOs are indeed profit-making operations. There are a few that are so-called not-for-profit, but that doesn't mean they don't make a profit. The not-for-profit is a tax status, strictly. It's a way of avoiding paying federal taxes. Theoretically, you don't return money to shareholders. You don't have shareholders with a not-for-profit. So you theoretically there you are not returning money to shareholders, but you're reinvesting any excess funding back into the organization. But the fact of the matter is that the executives in these things can make huge, ridiculously huge salaries. for doing the jobs. So it's just a matter. It's really, the question itself becomes meaningless because HMOs in general um, do make money, and the fact that they have to have sufficient reserves also says that. What's an underwriting cycle, a retention ratio, self-insured, um, 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 self-insured ASO. You can look these things up. Um, uh, ERISA, the Employee Income Security, Retirement Income Security Act. That's what that is. An underwriting cycle merely is a period of time when you are looking at what sort of risks you're willing to take and underwriting and agreeing to pay for those risks. Retention ratio is how many people stay in your system from year to year. Self-insured, you can self-insure. It's a risky thing unless you have a rather large financial reserve to cover something major, stroke, heart attack, a serious cancer, as opposed to something like basal cell carcinoma, which I'm not saying that it can't be serious, but it's relatively easy and cost effective to treat. Do HSAs reduce the cost of health insurance or shift it around? Depends on the structure. When HSAs first started, it was a use it or lose it kind of situation. Now it's not. You can recover that money. But basically, it's just a fire drill with the money. Winners and losers in managed care, that depends on who you talk to. The guys at the top make a lot of money. When we first moved back to Colorado in 1995, there was an HMO down in Pueblo that was bought by United Healthcare for $1 billion, and it was owned by a single physician. So who were the winners and losers? Well, he definitely was a winner. And the losers? Well, the patients. They cut staff, they cut salaries in order to pay for that purchase. It was a good example of why some of these mergers are a bad idea. Cost reductions mean that some doctors must earn lower incomes. One of the reasons that a lot of doctors won't take new Medicare patients is because of the cut in Medicare payments. So yeah, cost reductions mean that some are going to lower their income. Who are the winners and losers from HSAs? Well, clear winner, the banks, because they keep the money, they make money on that money. Does a physician, gatekeeper, or medical home work for or against the patient? It depends on the physician. For the most part, it's a way to keep the consumer from overusing the system. Years ago, we had a problem. Our daughter had a head injury, and so we were referred to various specialists. Went back to our primary physician and said, we don't like what these guys are saying, and so what happened next was, okay, well, you need to get a second opinion. We're going to send you to a pediatrician. Well, it was a head injury. Pediatricians see head injuries, there's no doubt about that, but they're not neurosurgeons. And I objected, saying, well, isn't it normal to go up the skill scale and training scale instead of down to more generalists? Basically it was, well, we want to be sure that this is really what the problem is, blah, 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 blah. But the opportunity I had at that point was to make it very clear what I wanted for my daughter. And what I wanted was a very, very specific pediatric neurosurgeon, who all of the medical people that we knew said was the best in Central North Carolina. Well, actually, the best in the region. So when I was asked the question, "What do you want for your daughter?" I simply described this particular physician without naming him. And they said, "Well, we're going to send you to," and they named the guy. So, but my goal was different than the insurance and the medical system's goal. Their goal was to save money. Mine was to get the best possible care for my daughter. And I had the resources, my wife and I had the resources, talking to all the physicians we knew and worked with, to get their view of who the very, very best was. So we managed to get that. But it was a case of working. The gatekeepers tried to keep the gates closed, and we kept opening them. So, and we were in a position to do that. Other people are not. That's the problem. Sources, employer-based group health insurance, Medicare, Medicaid. There's also, you can get individual insurance policy, at least here in Colorado. Okay. So we've got these statistics here about the number of people, elderly and non-elderly. Take a look at this. We got 38 million elderly folks. 93.2% of them are on Medicare. Now, I don't know what they define as elderly, probably 65 and up. Medicaid, a little bit under 9%, so a little under 2% are uninsured. Of the non-elderly, that's 17% of 272 million, which is closing in on 50 million people, which is a lot. Again, this is 2011 numbers probably, up 2012. Annual premiums, so we've got, look at these. Here are the total premiums, and here are what the employees pay, individual or family. And with the deductibles and the max out of pocket, these numbers have shifted tremendously in the last couple of years. Believe me, you probably know that. You can now get insurance policies that are that have deductibles of thousands of dollars, $5,000-$10,000, and max out of pocket $10,000 to $20,000 for a pretty low price if you're healthy. If you're not healthy, you can't get any insurance at all. Sometimes. Still, it's very difficult. Percentage of workers insured by the size of the firm. So 1,000, the more people in the firm that are insured, the higher the percentage. Part of this is because if you got 1 to 9, if you only have 8 people insured, then you're talking about only 89%. And so it's these numbers are a bit wonky in my book, or in my view. These are kind of irrelevant because all of this changes and is dependent on the state, and all of this is very, very different. If you look at this, this is a publication from the Center for Medicare and Medicaid Services, 2002. We can look at some of these Medicare supplement programs. Medicare pays 80%, you pay 20%. The supplement programs are cover that other 20%. And in reality, Part A is hospitalization, et cetera. that's what you've paid for 100% with your 1.45% Medicare tax. And Part B is something that you buy when you go on to Medicare. And Part B covers doctors' offices and other kinds of things. We now have Part D as well. We have, which is the prescription drug plan. And we have these Part C is basically what they're talking about here with these supplement plans. Part C terminology is starting to go away. We have a Medicare supplement or Medicare Advantage, or lots and lots of terms that we use, but it adds to these. We have plans that run from very basic plans covering only basic benefits, and high can be very variable deductibles, up to some of these really top level plans where you can have all sorts of other coverage, sometimes with much higher deductibles. What's the source? And again, we're seeing some of these things change as time goes on. We've got state, we've got the CHIP program, we've got other government plans as well. So this is in addition to private insurance and government. Contracting insurance companies basically are in the middle. All they are is a conduit of funds. We have an awful lot of different ways of approaching it. We have fixed premium plans, self-insurance. We have Medicare for a lot of other things. We have all sorts of plans, and they change every year. So our book is not totally up to date in terms of what is currently available here. We have a lot of other things to look at. The medical loss ratio is as a percent of the premium. The issue is that the idea of medical loss is interesting. You can read some more about that in the text, but medical loss is what costs are. The underwriting cycle basically is related to insurance premium versus costs, and we see that the growth in medical costs has been outpaced over the years by the actual growth in insurance premiums. There were a few years where insurance premiums grew at a slower pace than the increase in medical costs, because it takes a little while for those premiums to be readjusted. It's like anything else. Your car slows down going uphill even if you step on the gas. And when you step on the gas, it takes a little while for you to start going faster going uphill. Same with coming down. You're going faster until you put the brake on it in order for your own safety. So there's a lag between those increases. Is that lag, if we look at this particular curve, does it look like insurance costs are going up much faster than they should? That's an argument that you could make. Okay, so here we've had a little bit of look, real per capita spending, 1960 to 2012. So we see that it really has ramped up. Medicare, well, we know why Medicare, because because the baby boomers are coming online. At that time, the 65-year age for retirement, for Medicare, for Social Security, were all set based on Social Security, and Social Security was enacted under Franklin Roosevelt in the 30s, 1930s, because of the collapse of the economic system in the Great Depression. But we also had people who had nothing. I mean, they work all their lives and had nothing. So, but the Social Security system was set up as, again, a tax. It's a tax. You pay into a fund. And the age of 65 was chosen because that was actually older than the average age at death at the time the system was put in place. So the system was actually set up to, on average, not pay out. So that's one of the reasons we're looking at this. Defined contribution health plans are basically you contribute X amount, and that's a defined contribution, and you get a defined amount of health care for it. There are all sorts of different managed cares. This list of arrangements is partially out of date. But we still have essentially all of these things. We have the managed care contracts are the main ones are point of service. Basically, you pay at the time you get the service, and then claims are filed. Preferred provider organizations are organizations that will allow you to go where you want, but they will pay a fixed amount, and you're going to have to pay a premium if you go to someone out of their network. Same with a point of service network. HMOs are the most restrictive. You need to go to their people, and their people generally only. So here is an example of a preferred provider organization structure. Hospital within the network, they would cover 100%. If you went to an out-of-network hospital, they would only cover 80. Physicians, again, you'll have a copay, physicians and therapists, etc. So all of these things, and in the drug realm, we have drugs that are covered and drugs that are not covered. If you are prescribed a drug that isn't covered, you're going to be looking at an out-of-pocket cost sometimes of hundreds of dollars. So these things are common. Managed care. So we have premiums. Price, quantity is the number of people on it, and then there's an overhead added in to make money. Insurance companies don't lose money. Just keep that in mind. Insurance companies have really set things up by not losing money. So they make money by several things. They can charge more, or they can pay out less, or most of them will do both. If you control you're in control of those. Okay. So that's what I really wanted to say. Let's go back to our assignments here. I urge you to go ahead and, come on, wake up, sleepyhead. All right. You have a discussion this week. I urge you to have picked out a question and be working on it. Get that to me as soon as you can. week one assignment. The assignments, you had a specific assignment for assignment 1, and then you had the reading assignments for 2, and take your assessment. I've seen that you've already started doing daily checkpoints, which I thank you for keeping up on those. Anyway, I'm going to cut this off now. That's really what I wanted to say. If you have questions, go ahead and email me, and I will talk to you bright and early Monday morning. Hope you have a good weekend, Crystal.